I'm Erin Ferranti, and I have the pleasure of introducing Dr. Ingram. Dr. Ingram is with us today to present a talk on intra-abdominal adiposity and physical activity as early predictors of maternal metabolic health. She comes to us from Kennesaw State University. She leads an interdisciplinary research program at KSU focused on preventing and managing cardiometabolic diseases through physical activity and diet. Her team studies early diabetes predictors during pregnancy, and her work is supported by NIH funding. She co-founded GlucoCheck, an AI-powered smart ring for non-invasive glucose monitoring. So cool. And her work has received funding from Georgia Research Alliance and NIH. Her mentorship has been recognized with national awards, including a 2021 Health Sciences Undergraduate Mentor Award and a 2022 NIH DEIA Mentorship supplement. So we're so thrilled to have you, and I'm so excited to meet you because my work is in maternal health as well. So I will turn it over to you.
So, as Erin said, my name is Katherine Ingram. I'm at Kennesaw State University, and I study the relationship between metabolic health and central adiposity, among several other things, but that's the primary focus, and that's what I'd like to share with you today. I'm going to start out by providing you a little bit of a background about obesity and diabetes and the way that central adiposity manifests some very particular relationships. And then I'll share some data that we've collected in our laboratory and some other places. So the focus of my laboratory is looking at the relationships between physical activity, abdominal adiposity, and metabolic health. And I'm very interested in using this information to identify easy predictors for metabolic disease. One thing that we do in particular is we expose students to research in our laboratory and focus on providing them with a lot of experience. As Erin said, I have received some funding and awards for mentorship with underrepresented backgrounds. But at this point, I don't know if I'm able to say that or not. As you probably are familiar, obesity in the United States is growing very rapidly. Right now, there's a prevalence of 39.8% in U.S. adults, with higher rates seen in non-white populations. Also alarming is that childhood obesity is on the rise. It has doubled from its prevalence in at the turn of the century, the year 2000, from 10% to 19% in 15 years. Also, we've seen a huge rise in young children who have class 1 obesity. It rose from 8% to 13% just in a span of 5 years, roughly. What makes this so alarming is just the way it will perpetuate. Obese children and adolescents are 5 times more likely to be obese in adulthood than those who aren't obese. I found this chart very interesting from a current study looking at the year people were born and how the trajectories have changed for risk factors for obesity. And we noticed that the slopes of these trajectories have become more and more vertical the younger people are. So it's pointing to the obesogenic nature of the United States and the projection of our youngest citizens over the course of their lifespan. So the people who are born latest have a much higher risk for developing obesity than people who are born later or earlier, sorry. There's one specific group that is very interesting to me to study, as this is one that is really influential in transgenerational obesity. And it's the older female adolescents. And like the other groups, we've seen a huge increase in obesity and overweight in these groups. In particular, the prevalence was approximately 30% at the turn of the century in 2000. And as of now, it's up to over 50% with overweight or obesity. And it really underscores the burden of obesity in young women entering adulthood. And this is particularly relevant to my work because it directly addresses maternal obesity. These are adolescents who are going to be entering the years where they may become pregnant. And when it comes to obesity status, there are a variety of poor pregnancy outcomes, excuse me, that are associated with. So maternal obesity is associated with a higher risk for C-sections. It's associated with a higher risk for hypertension or preeclampsia. And it's the strongest modifiable risk factor known now for gestational diabetes. Obesity, in fact, is so very tightly linked to gestational diabetes that some 46% of gestational diabetes can be directly related to pre-pregnancy obesity and overweight. Overweight individuals have twice a risk of developing gestational diabetes as those who are lean, whereas those in the higher class of obesity, class 3 obesity, have over an 8% or eightfold risk for developing gestational diabetes. So the current prevalence of gestational diabetes, depending on the research study, is over 9% of pregnancies in the United States. And it varies from study to study, depending on the sample population, of course, but research is generally in agreement that it's roughly 8 to 12% of pregnancies. And the rate is currently rising, or seems to be rising over time, and exacerbated by the prevalence of maternal obesity and the increasing maternal age. So another interesting association that we've seen is that diabetes in youth is climbing in parallel with the rise in gestational diabetes. Both maternal obesity and gestational diabetes have been independently associated with risk of type 2 diabetes in the offspring. Other poor outcomes that we see from gestational diabetes, we see macrosomia at birth. We see that the children born from gestational diabetes tend to maintain overweight or obese status throughout their childhood. And they often will develop abnormal glucose metabolism or metabolic syndrome or type 2 diabetes. So all of this leads up to this transgenerational cycle of obesity and diabetes. When women enter the age of pregnancy, already already overweight or obese, they're at much higher risk for developing gestational diabetes. And then their children are more at risk for having overweight, obesity, and diabetes as well. And so once those offspring come of age, then they have a higher risk of gestational diabetes as well. So this creates this transgenerational cycle where maternal obesity and gestational diabetes puts the offspring at risk for obesity and type 2 diabetes and future risk for gestational diabetes. A statistic that I wanted to point out is that 47% of type 2 diabetes in youth can be attributed to an intrauterine exposure to maternal obesity and diabetes. So this underscores the need for action that can help to reduce and prevent obesity and diabetes before and during pregnancy. Research is showing that it's not only obesity itself that causes or that is associated with insulin sensitivity and metabolic dysfunction of pregnancy, but in particular, it's the distribution of fat, and particularly to the central region that is associated with insulin resistance. And studies have shown that a central fat accumulation is associated with insulin resistance independent of overall obesity. Abdominal fat, that's visceral or the deep abdominal fat, is thought to be considered a marker of lipid infiltration in the liver and considered to be a byproduct of metabolic dysfunction. We've seen that this abdominal obesity is associated with inflammation as part of reduced insulin sensitivity. And another observation that's been made is that the inflammation found in pregnancy associated with obesity is lower in active individuals versus inactive individuals, indicating that exercise has a role to play in mitigating this systemic inflammation. The inflammation itself is considered to have a contributing role to the disruption of the metabolic processes and impacts insulin sensitivity, though the research hasn't completely delineated this. More is needed in this. In my work, I have found similar associations between abdominal fat accumulation, shown in the figure here. Intra-abdominal adipose tissue was found to be negatively associated with insulin sensitivity in this study, while on the flip side, lower body adiposity, noted as leg fat here, is associated with more of a protective status, that it has a strong association with a improved insulin sensitivity. I've spent some time working with the cardia data set, particularly studies having to do with obesity and diabetes. And one of the studies that we found looked at the cardiometabolic risk factors that are associated with gestational diabetes in women both before and after pregnancies. One thing that was found in this data set, the data set was 1,300 women. 12% of these developed gestational diabetes. They found that there was a higher body weight and higher waist girth that were detected in the pre-pregnancy years in the women who later on developed gestational diabetes. Yet more evidence pointing to the tight relationship between abdominal adiposity and insulin resistance. Now, additionally, I study how exercise fits into this. And we see that there is a good association between central adiposity and poor metabolic outcomes in pregnancy. But we're seeing that exercise and fitness are associated with the opposite, with some positive outcomes. Oops, I didn't mean to move that. So in cardia, we've noticed over the years that that cardiorespiratory fitness has been associated with a reduced risk for prediabetes and diabetes. So we looked at this in the cardia data set in women who developed gestational diabetes. So it was 1,320 women, 162 cases of gestational diabetes. And we found that in this data, the cardiorespiratory fitness assessed by a treadmill test, a graded exercise test, was a better predictor of gestational diabetes than the daily physical activity. The data indicated that for every standard deviation increment in pre-pregnancy fitness, there was a 21% lower rate of incident gestational diabetes, and that's in our adjusted model. We found that the physical activity itself was not associated with gestational diabetes. It was more the fitness that came from all of the physical activity. So in my current lab, I've been working on using measures of abdominal fat taken by ultrasound. And I utilize 4 different measures that I take. One is intra-abdominal adipose tissue taken close to the umbilicus. I look at the subcutaneous fat that's right above that. And then up closer to the xiphoid process, I measure preperitoneal fat and the subcutaneous fat that's there as well. I conducted a study to look at whether these 4 measures of abdominal fat how they associate with insulin resistance of pregnancy and how physical activity associates with both of these measures. So looking at the association among the 3 together and how they're associated. In this one particular study, we had 32 pregnant women who came in at around 20 weeks of pregnancy. This assessment was taken right around their 20-week visit with their clinician. And we took the ultrasound measures in the clinician's office. The ultrasound technician took the measures, and then they came to our lab at Kennesaw State, and we measured a variety of other things. We measured body composition in a variety of different ways. We measured physical activity through accelerometry and also through the PPAC questionnaire, the Pregnancy Physical Activity Questionnaire. We our major outcome variable was insulin resistance measured at their normal glucose challenge test. With this particular study, we utilized HOMA as our main outcome variable of insulin resistance. And I wanted to point out, as I'm sharing the details of this study, what the different measures of abdominal fat are looking at. This particular measure is a CT scan of the abdominal region. And I want to show you that intra-abdominal adipose tissue is this area that's right around, it's where the fat that accumulates right around the organs within the abdominal cavity. Subcutaneous fat would be the outer layer of abdominal tissue. Now with ultrasound, we can't, well, I'll show you what an ultrasound measure does. So with ultrasound, we're looking at intra-abdominal adipose at the level of the umbilicus, preperitoneal at the level of the xiphoid process. And with the intra-abdominal adipose, we are able to visualize through ultrasound the fat thickness from the descending abdominal aorta up to this, this tissue, the linea alba, and that is considered the deeper intra-abdominal adipose tissue. And then we take another measure right above it for the subcutaneous fat tissue. In this study, we had the 32 pregnant participants. As I shared with you already, we looked at body composition at around their 20-week visit. And we looked at these 4 measures of ultrasound abdominal tissue. And we used the HOMA IR as our main outcome. And what we found was, as we hypothesized, that insulin resistance was strongly associated with all of our body fat measures, and it was particularly strongly associated with our central fat measures, specifically the ones by the umbilicus, the intra-abdominal adipose tissue, and the subcutaneous adipose tissue. When we further computed the intra-abdominal adipose tissue as a proportion of its whole thickness, so measuring what proportion of the thickness from the intra-abdominal adipose tissue and its subcutaneous adipose tissue on top of it, we found that provided the strongest prediction for HOMA IR. We looked at a variety of different measures in this study, including if we only looked at the fat mass and the lean mass of the person as predictors of HOMA, we found a significant relationship. However, it was when we looked specifically at the proportion of abdominal fat thickness coming from the deep tissue, the intra-abdominal adipose, in a model also including pre-pregnancy BMI and their gestational age, we found a very strong relationship of an R-square of 0.59, which shows that this type of ultrasound measure may have good use for clinical prediction of people at risk for metabolic issues or gestational diabetes. We also looked at a group of non-pregnant women. We were interested in improving our methods to move really beyond using HOMA, which was the only thing that was available to us in our first study, We have, in this study, introduced a glucose tolerance test. And we found the Matsuda index, which is a measure of insulin sensitivity using the dynamic measures from a glucose tolerance test. With this, we found that insulin sensitivity was strongly and indirectly related to intra-abdominal adipose tissue, as we found before in the pregnancy model. Also, it was strongly and indirectly associated with waist circumference. And in the non-pregnant individuals, it was not strongly associated with subcutaneous adipose tissue. In this study, we also looked at accelerometry and calculated how many steps these individuals were moving every day. And in this study, we found that the intra-abdominal adipose tissue was not directly associated with their steps per day. However, the subcutaneous adipose tissue was associated with steps per day. So indicating that there is an independent and divergent effect of physical activity and insulin sensitivity in its association with abdominal adipose tissue accretion. In our pregnant individuals, we found that that physical activity was also associated with our value measures for insulin resistance. HOMA was strongly associated with the sedentary behavior that was indicated on their physical activity questionnaire. We found some differences in our relationships between the least active versus the most active women in this study. We found that similar to the previous study in non-pregnant women, in these women, we also found that steps per minute was associated with the subcutaneous adipose tissue, but not the intra-abdominal adipose tissue. So with the expectation that physical activity has a mediating role in the relationship between abdominal fat distribution and insulin sensitivity. Another finding that that's from our visceral fat study looking at women in pregnancy, we found an interesting relationship between insulin resistance and lower body fat distribution. We found that after pregnancy, lower body fat distribution was indirectly associated with HOMA, our measure of insulin resistance. So this indicates that, or more supports the hypothesis that fat distribution to the lower body has sort of a protective relationship with insulin resistance. In our work, we've been using the HOMA-IR, which, as I mentioned before, is just a fasting measure of insulin resistance. And it's widely thought that these may not be the best measures of insulin resistance when considering gestational diabetes. And this, the reason it could be improved is because of the heterogeneous presentation of gestational diabetes, where in gestational diabetes, we see that both insulin sensitivity is impaired and there's a beta cell compensation that's inadequate. So in gestational diabetes, some of the cases have more issues with insulin sensitivity, while other cases have more issues with beta cell secretion of insulin. And so when studying gestational diabetes, it's ideal if you can test both of these processes together. And so currently our studies are using frequently sampled oral glucose tolerance tests and computed with minimal modeling so that we can test each of these items separately. One of our major goals for all of this work is finding measures that can have more of a clinical significance. Can we develop these measures into prediction, useful prediction formula or tools that can be used for people to determine whether they're at heightened risk for maternal metabolic issues? Our current study, which we are just winding up now, we are testing both the independent and interaction effects of abdominal fat accumulation using ultrasound to measure those 4 abdominal fat locations that I've already shared with you. We're also incorporating into our prediction sedentary behaviors during pregnancy through the use of accelerometry and physical activity questionnaires. In addition, we are incorporating cardiorespiratory fitness through treadmill testing. We're testing these factors to be independent predictors of gestational diabetes risk, testing each on their associations with insulin sensitivity and on their associations with beta cell function that we get from our minimal model computation after the oral glucose tolerance test. So our hypothesis is that we will find that that abdominal adiposity is tightly associated with insulin sensitivity and beta cell function. We also hypothesize that it will be more the cardiorespiratory fitness rather than the daily physical activity that is most impactful on metabolic health. In our most current study, we have found that there are some protocol considerations that aren't being addressed in the literature, and one of which is a very simple concept. The angle of the exam table when assessing ultrasound. Ultrasound is becoming more widely used as a method for assessing abdominal fat. However, no one in the literature has yet published anything on the angle of the table and whether that impacts the measures that we're taking. And so we conducted this study using our current study. And what we found is that
Baby, can you mute, please? We're hearing background noise.
Thank you.
Wendy, are you able to mute? Okay, there we go.
Thank you. I realized I went on mute too. So we have now studied as part of this, our current program, how the exam table angle is affecting the thickness measures that we take. So we found that there actually is a wide variability in thickness that results from changing the table angle that the participant is lying is the table that the participant is lying on. I learned from several clinicians that the angle isn't necessarily standardized, so this is something that we are hopeful to implement. There we go. Other things that we are planning to do is hopefully our goal is to utilize our work to determine the ability of these factors to predict metabolic health. And our goal is to ultimately make these available for clinical use. Another area that we are focused on is developing the correct lifestyle interventions. So being able to determine what level of exercise dose is going to be the most useful for prevention of gestational diabetes. Just for some background there have been a lot of conflicting studies that have presented physical activity as a potential way to prevent gestational diabetes. However, the findings are very, very mixed, and it seems evident that this has to do with differences in intensity of exercise. So our goal would be to determine what is the right intensity of exercise to have the best impact. Another goal of ours is to use glycemic variability in the prevention of gestational diabetes or mitigation of gestational diabetes. Other thoughts that we would like to roll into our program, other environmental interactions, including all the various aspects of the exposome, sleep hygiene, environmental contaminants, dietary factors, glycemic control, as I mentioned, and COVID infections. All of these we believe may have an impact and should be included in our considerations. And the people that have helped us along the way, we've received funding from KSU's Office of Research and our college, through the NIH, NICHD, and through the NIDDK Step Up program, who have generously funded some of our scholars, and other collaborators we have worked with along the way. And I want to thank you for your time, and I'm happy to take questions.
Thank you so much, Dr. Ingram. That was really fascinating. Feel free, if anybody has any questions, to come off mute and ask, or if you prefer to put in the chat, I'm happy to read them out as well. I actually have a question, and
Sure.
definitely personally interested in, and I may have missed it, but testing the both the defect in insulin sensitivity and the beta cell secretion of insulin. So you mentioned, of course, the oral glucose tolerance test and then the minimal model computation. Can you explain more about what that it is?
Yeah, so with the oral glucose tolerance test, we take frequently sampled frequent blood samples at 0, 10, 20, 30, 60, 90, and 120 minutes. And we, through these, we assay for blood glucose, insulin, and C-peptide. And we can model these to determine hepatic secretion, pancreatic secretion, and insulin sensitivity through charting it over time.
Awesome. Okay, great. Thanks. And there's a question in the chat. from Yoon Wang. How do we consider the metabolic healthy obesity during pregnancy? How do we consider metabolic healthy obesity during pregnancy?
Well, so metabolism is a function of more than just abdominal fat, or more than just overall fat. So, uh, um, I think the use, well, a lot of risk for gestational diabetes and metabolic health has to do with genetic predisposition and physical activity as well. Um, this is why we focus on abdominal adipose secretion, because people can be quite lean but carry a higher proportion of intra-abdominal or abdominal fat around their organs, and that is more strongly associated than overall obesity. I don't know if that answers your question.
Sorry, I should explain my question a little bit
Sure.
better. This is young. So I'm recently I read a little bit more about the metabolic healthy obesity, and it doesn't seem that they consider the fat as one of those criteria, because it just people are obese according to the BMI, but their metabolic is healthy biomarkers. So that's kind of curious how you handle this during in your study, or this is also confusing to me how to really do this. Yeah.
Yeah, when you say metabolically healthy, are you referring to people who are overweight but then have are very insulin sensitive? Is that what you're referring to?
Yeah, they're overweight or obese according to the BMI, but their metabolic biomarkers like insulin, glucose, all those biomarkers are in the healthy range. Um, yeah.
Yeah, so BMI itself, it doesn't address body fat at all.
Mhm.
Um, so that's something that I would have to be considered very individually. BMI could present quite high if a person comes in very muscular, and it could present low in people even who have a low muscle mass too, even if they appear lean. Or I'm sorry, even if um I said that backwards. If BMI could appear high in people who are lean but muscular, but it could also appear low in people who have low lean or low muscle mass too. Does that make sense?
Yeah, I just need to read more because I'm not really a BC researcher. Just recently, I got more interest in that. Many because the reviewers that preventing obesity, insulin, glucose is not efficient to measure the metabolic health. So kind of want to know
Hmm.
more about this part. Yeah.
Yeah, well, I would be happy to brainstorm with you. But I think I think that scientists really need to look at the difference in body composition as more fat versus muscle mass. I think that if you're looking just at BMI, you're missing a huge part of the picture. So that might create some noise in those factors.
Katherine, I know Jean has her hand up, but there was a question in the chat too. So we'll do the chat one first and then go to Jean. So the question is, do you think it's a good start to do retrospective analysis of abdominal CT scans done for any other indications to investigate the relationship between CT-derived abdominal fat distribution and clinical metabolic health profile in resource-limited settings?
Well, I think in resource limited settings, it actually, um, I think there is good good value in understanding those relationships. In resource limited settings, I would expect that that's even a greater need for what we are doing using ultrasound rather than CT or MRI, as these are more readily accessible in clinics.
Okay, my turn.
Yep.
So
Jean.
talk about nice to see you, Dr. Ingram, and nice, interesting presentation. So I'm curious about the value, talking really limited resource setting, and the value of just the plain waist circumference and
Yes.
how to maximize it. Is it something that should be? It seemed like there was value. There was some predictive value in the waist circumference. How does that be done right? Or is the best way to maximize its usefulness?
Absolutely. I think that waist circumference is a fantastic way to assess abdominal adiposity. Some people are looking at a waist circumference height ratio instead of like waist to hip ratio. Yeah. And I can see the usefulness for that. I haven't seen the most current data on that, but if the resource limited clinics are not using waist circumference, I would definitely urge them to do so. I think that could provide a lot more information over the long run.
Thank you.
Sarah, do you want to come off mute and ask your question?
Sure. Thank you so much for a great presentation. I was just wondering if there are any limitations of using the BIA machine for pregnant women, like in terms of health and just like accuracy of using it, given that all the different body composition changes during pregnancy.
Yeah, well, we've studied that very extensively. We focus a lot on body composition measures, and in fact, we just validated one of our bioimpedance machines against total body water. And we chose to do that because body water is a concern in pregnancy with various fluctuations. So what we found is that body water is validated, or a valid assessment within bioimpedance. So knowing that gave us a little bit, some good confidence in using the bioimpedance for pregnancy. But keep in mind that bioimpedance has some limitations because their particular hydration level will influence the findings or the results of their tests, and and eating right beforehand can also cause some bias in their results. So it's important that if you use bioimpedance, that the participants are asked to keep meals small and ideally fast for the 4 hours or so before taking their measures, and abstain from drinking water until after their test. Also, like diet for those 4 hours before. We also, as another measure, ask all of our participants to void their bladder right before we measure on bioimpedance. So the idea is to really control body water fluctuations that are happening immediately when using those devices.
Any other final questions before we wrap up?
Just wondering about, are you doing any follow-up with kids? With the offspring?
Yeah, we haven't, but we'd love to. We've been asked this a few times. We haven't, but we could.
Okay, we'll talk.
Yeah, that would be great. I'd love to.
Thank you very much. Very interesting.
Yeah, thank you.
Thank you so much for attending this talk. The talk will be available on our YouTube channel, GCDTR. I've put the link in the chat. And have a great rest of your week, everyone.